Welcome to a new episode of NeoMed AI Podcast, the podcast that offers insightful AI for better neonatal care. Today, we are tackling one of the most challenging neonatal emergencies, persistent pulmonary hypertension of the newborn, or PPHN.
It's a topic that demands our full attention. PPHN is a critical failure of the normal transition at birth, where the baby's lung blood pressure stays dangerously high. This leads to severe, often labile, hypoxemia, and it's a true neonatal emergency with significant risks.
Absolutely. Our mission today is to take a comprehensive look, starting with the foundational concepts, then moving into day-to-day clinical management, and finally exploring the really complex consultant-level challenges. We'll be grounding our discussion in evidence and current UK clinical standards.
Sounds like a plan. The key is to build that knowledge base from the ground up, just as we would when faced with a sick infant in front of us.
Exactly. So, let's start there. Imagine you're called to an emergency cesarean section. A term male infant is born at 40 plus 2 weeks gestation through thick meconium-stained liquor. APGAR scores are a bit low to start, 6 at 1 minute but up to 8 at 5 minutes. After initial resuscitation, he's in clear respiratory distress. He's breathing fast, you can see retractions, and he needs oxygen.
A classic worrying picture.
It gets more specific. By 2 hours of age, he's on high flow with 50% oxygen. You notice his pre-ductal saturation on his right hand is jumping around between 88 and 94%, but his post-ductal saturation on his foot is stuck down at 82 to 85%. For you listening, what's going through your mind? But for us, what is that saturation difference screaming at you?
That pre- and post-ductal saturation difference is the key clinical sign. A gap of more than 5 to 10% is highly suggestive of a right-to-left shunt at the level of the ductus arteriosus. It means deoxygenated blood from the pulmonary artery is bypassing the lungs, crossing the duct, and flowing down into the body, hence the lower sats on the foot. While we need to consider other things, like structural heart disease or severe lung disease, PPHN is top of the list.
And fundamentally, what is the core process that has gone wrong here?
It's all about the failure of that crucial postnatal drop in pulmonary vascular resistance, the PVR. In the womb, the PVR is high, and very little blood goes to the lungs. At birth, when the baby takes its first breaths, the lungs fill with air, and the rise in oxygen should trigger a dramatic fall in that resistance. In PPHN, that simply fails to happen. The pressure in the lungs' arteries remains as high or even higher than the body's systemic pressure. This forces deoxygenated blood to shunt from right to left through the fetal channels, the ductus arteriosus and the foramen ovale, bypassing the lungs entirely and causing profound systemic hypoxemia.
Given the history you just heard, the thick meconium, what's the most likely trigger for this cascade?
It's almost certainly meconium aspiration syndrome, or MAS. MAS is a potent trigger for PPHN. It works in a few ways. There's mechanical blockage of the airways, a nasty chemical inflammation, and it inactivates the baby's own surfactant. All of this leads to hypoxia and acidosis, which are powerful pulmonary vasoconstrictors that clamp those vessels down and keep the PVR sky high.
You mentioned different ways PPHN can develop. Can you briefly break down the main types?
Of course, we tend to think of it in 3 categories. The most common is maladaptation, where the lung vessels are structurally normal, but are just clamped down and constricted, usually due to a trigger like MAS, sepsis, or birth asphyxia. Then there's maldevelopment, where the arteries have actually grown abnormally in the womb, with too much muscle in their walls. This can be idiopathic or linked to chronic fetal stress. Finally, there's underdevelopment, where there's a physical lack of lung vessels, which we see in conditions like a congenital diaphragmatic hernia or Potter syndrome.
Just to ground us, how common is this in the UK?
The reported incidence is around 2 per 1,000 live births. It's most common in term and late preterm infants, so those born at or after 34 weeks gestation.
So for this infant, with that clear pre- and post-ductal difference and the history of MAS, the diagnosis of PPHN is highly likely. You can't wait. What's the gold standard investigation you need to confirm this and guide your next steps?
Echocardiography. Without a doubt, it is absolutely crucial. An echo confirms the diagnosis by showing the high pulmonary artery pressure, often by looking at the speed of the tricuspid regurgitation jet. It shows us the direction and size of the shunts across the ductus and the foramen ovale. Crucially, it lets us assess how the left and right ventricles are coping with the strain. And perhaps most importantly, it rules out a structural congenital heart disease that could be mimicking PPHN, which is a vital distinction to make.
Before we get into specific treatments, what are your overarching principles of your initial management?
The goals are twofold: improve blood flow to the lungs and boost systemic oxygenation, all while trying not to cause any further damage, particularly to the lungs. This means we need to optimize their ventilation, maintain their systemic blood pressure to be higher than their lung pressure, correct any acidosis, and provide good sedation to stop stress from causing more pulmonary vasoconstriction. It's important to remember that oxygen itself is a potent, if non-specific, pulmonary vasodilator. So getting that right is a key first step.
And thinking about the bigger picture, with a condition this severe, what's the prognosis?
It remains very serious. Even with all our modern therapies, mortality is still quoted between 4 and 33%, depending heavily on what caused it and how severe it is. For the survivors, there's a significant risk of long-term problems. Up to 25% can have neurodevelopmental impairment, which includes things like cerebral palsy, developmental delay, and a well-documented risk of sensorineural hearing loss. It's a diagnosis with lifelong implications.
That really frames the stakes. Let's move the case forward. Our infant has now been intubated and moved to the NICU. He's got an arterial line and central lines in. His first blood gas on 100% oxygen shows a pH of 7.28, a high PCO2 of 6.8, and a very low PO2 of 5.5 kilopascals. The echo confirms everything: a structurally normal heart but severe pulmonary hypertension with right ventricular pressures that are suprasystemic, higher than the body's pressure. There's a big right-to-left shunt across the ductus, and the interventricular septum is flattened, which is a sign of that immense right heart pressure. Based on all that, what is your immediate next therapeutic step?
The immediate step is to start inhaled nitric oxide, or INO. This infant has severe hypoxemic respiratory failure with clear echo evidence of PPHN. His oxygenation index, or OI, which is a measure of how much support he needs, is clearly very high. I'd calculate it as being well over 25. An OI over 20 to 25 is a standard threshold to start INO in UK practice. The standard starting dose is 20 parts per million.
Let's dive into that. How exactly does nitric oxide work?
It's a brilliant therapy because it's a selective pulmonary vasodilator. When the baby inhales it, the gas goes into the alveoli and diffuses directly to the smooth muscle of the adjacent blood vessels. There, it triggers a chemical cascade that increases a molecule called GMP, which causes the muscle to relax and the vessel to dilate. The genius of it is that as soon as it enters the bloodstream, it's immediately inactivated by hemoglobin. This means its effect is localized only to the parts of the lungs that are being ventilated, which improves the matching of ventilation and perfusion, and it does all this without causing systemic hypotension or low blood pressure in the rest of the body.
And while you're starting INO, what are your specific goals for the ventilator? It's not just about oxygen, is it?
Not at all. The buzzword is gentle ventilation. The goal is to recruit the lung to open it up without over-distending it, because hyperinflation can actually squash the pulmonary vessels and make the PVR worse. That's why the gentle ventilation concept is so important. We aim to get good lung volume, maybe 8 to 9 ribs expanded on the chest X-ray, to get the best VQ matching. We want to target normocarbia, a normal CO2 level of around 5 to 6 kPa, because high CO2 is a vasoconstrictor, but we've moved away from the old practice of causing a deep respiratory alkalosis, as that can dangerously reduce blood flow to the brain. And for oxygen, we aim for a pre-ductal saturation of 92 to 97%, avoiding both hypoxia and hyperoxia, which causes its own oxidative stress.
If we're needing very high pressures on a conventional ventilator, we'd also consider switching to high-frequency oscillation ventilation, or HFOV.
You start the INO. How do you know if it's working? What defines a response?
A positive response is a clear and sustained improvement in oxygenation. We're looking for the PaO2 to increase by more than 2 or 3 kPa, or the pre-ductal saturation to jump by more than 10% within about 30 to 60 minutes of starting. This improvement should allow you to start weaning the FiO2. It's important to know that about 30 to 40% of infants are non-responders, which tells you the problem is very severe.
Let's talk about the circulation. The echo showed the right heart pressure was higher than the systemic pressure. How do you manage the cardiovascular side of things?
This is absolutely critical. You have to maintain systemic blood pressure. The goal is to keep the systemic pressure higher than the pulmonary pressure to reduce that right to left shunt and also to ensure good blood flow to the heart muscle itself. If the baby's hypotensive, we might give a cautious fluid bolus, but we quickly move to inotropes. In the UK, a common approach is to use dopamine or adrenaline to really support that systemic vascular resistance and cardiac contractility. If there's evidence of significant ventricular dysfunction, especially on the right side, we'd also consider milrinone. It's an inotrope, but also a vasodilator, so it can help the heart pump better while also helping to lower both systemic and pulmonary resistance.
And what about surfactant? The primary problem is vascular, but this case was triggered by meconium aspiration.
Yes, you definitely give surfactant. In any case of PPHN that's secondary to a parenchymal lung disease like MAS or RDS, giving surfactant is recommended. It improves lung compliance, which means we can use gentler ventilator settings, and it improves the VQ mismatch. Both of those things will indirectly help to lower the PVR. A standard dose of 200 milligrams per kilogram of a natural surfactant would be appropriate.
Thinking about practical wisdom, what's a key pearl here for clinicians at the bedside?
A huge one is to anticipate lability. These babies are incredibly fragile. Minimal handling, a quiet, dark environment, and excellent sedation are just as important as the drugs and the ventilator. Any stress, pain, or agitation can trigger a dramatic spike in their pulmonary pressure and a sudden desaturation. Good nursing care and sedation are frontline therapy.
And a common pitfall to avoid?
Overventilating the lungs. It's tempting to use higher pressures to chase a better oxygen level, but hyperinflation can compress the alveolar capillaries and paradoxically increase the PVR, making everything worse. That's why the gentle ventilation concept is so important.
Okay, this is a very sick baby, and despite all these measures, the situation isn't improving. Let's make the case more complex. It's now 12 hours later, the infant is still on 100% oxygen, INO at 20 ppm, and is on an adrenaline infusion to keep his blood pressure up. But his pre-ductal PaO2 is stuck below 6.0 kilopascals, and his oxygenation index is consistently above 40. A repeat echo shows the right ventricle is now severely dilated and failing. What are the primary management options now for this infant with INO refractory PPHN?
This is grim territory. At this point, with an OI consistently over 40, despite maximal medical therapy, the primary management option is referral for extracorporeal oxygenation or ECMO. This infant meets the standard UK criteria. He's over 34 weeks, over 2 kilograms, has what should be reversible lung disease, and an OI over 40. ECMO is the definitive rescue therapy for this level of cardiorespiratory failure.
So you're picking up the phone to the National ECMO Service. What's the evidence for that decision?
The evidence is rock solid. The landmark UK collaborative ECMO trial from 1996 was a game changer. It showed a dramatic survival benefit for infants with severe respiratory failure treated with ECMO compared to sticking with conventional ventilation. Survival to 1 year without disability was 68% in the ECMO group versus just 41% in the conventional management group. It remains the standard of care for refractory cases that meet the criteria.
While you're waiting for the ECMO team, you have this baby with a failing right ventricle. This is where we get into some really niche, controversial therapies. What might you consider, specifically to help that failing RV and get him stable for transport?
This is a crucial consultant-level decision. With a severely failing RV and suprasystemic pressures, the right-to-left shunt across the ductus is actually acting as a pop-off valve. It's decompressing the RV and allowing some cardiac output to be maintained. If that ductus were to close, the RV would fail completely, leading to circulatory collapse. So the controversial but potentially life-saving intervention is to start a prostaglandin E1 or prostin infusion. We do this specifically to keep the ductus arteriosus open to protect the RV during the extremely high-risk period of transport to the ECMO center.
That's fascinating. Using a drug we typically associate with cardiac lesions to manage PPHN. What are the risks of that strategy?
The risks are significant. Prostaglandin is a systemic vasodilator, so the main risk is profound systemic hypotension, which can actually worsen the shunt. It requires a very delicate balancing act, often needing a simultaneous higher-dose vasopressin, like adrenaline, to counteract the hypotension and maintain perfusion. It's a bridge to ECMO, and you have to communicate those risks very clearly to the transport team.
Let's shift to another complex scenario. You have a term infant with black lung PPHN, meaning the lungs look clear on X-ray despite profound hypoxemia, and they don't respond at all to I know. The family mentions a previous sibling died in the neonatal period with a similar illness. ECMO is started, but the baby just cannot be weaned. What diagnosis should you be considering now beyond typical PPHN?
In that scenario, with that family history and a complete failure to respond to any therapy, you have to strongly suspect a congenital or genetic disorder. The top of that list would be alveolar capillary dysplasia with misalignment of pulmonary veins, or ACD and MPV. This is often caused by mutations in a gene called FOX1. It's a condition where the fundamental architecture of the lung's blood supply is wrong. It's diagnosed by lung biopsy and, tragically, it has a near universally fatal prognosis.
That highlights the ethical weight of these situations. If you suspect ACD, what does that mean for continuing ECMO?
It's one of the toughest situations we face. The next step is to discuss sending urgent genetic testing for FOX1 and related genes and potentially a higher-risk lung biopsy. But the ethical dimension is that if ACD is confirmed, continuing ECMO support is futile. This requires an incredibly sensitive, multidisciplinary discussion with the family about the reality of the diagnosis and the appropriateness of redirecting care towards a palliative approach. It's about shared decision-making when there is no hope for recovery.
This has been incredibly comprehensive. Let's try and apply some of this with a couple of quick-fire scenarios for our listeners. First, a trainee-level case. A 38-weeker is cyanosed at 4 hours old. Pre-ductal sats are 91%, post-ductal are 80% in 70% oxygen. He's irritable with a noticeable right ventricular heave. What are the immediate actions?
Call for senior help immediately. Then it's an ABC approach. Secure the airway, low threshold to intubate, get pre- and post-ductal sats on, continuous monitoring, get EV access and send baseline bloods and a blood gas, arrange an urgent chest X-ray, and crucially, an urgent echo.
Perfect. Now for a consultant-level challenge. A 35-weeker, born after very long-term ruptured membranes, has severe I know refractory PPHN. OI is 45. The echo shows a very sick, dilated RV. You're preparing for ECMO transport. What's the controversial but potentially life-saving drug you consider?
A low-dose prostaglandin E1 infusion. The rationale is to keep the ductus arteriosus patent as a pop-off valve to decompress the failing right ventricle and maintain systemic blood flow during the high-risk period of transport to the ECMO center.
And finally, a thought to leave everyone with is that the management of these critically ill infants is a true team sport, involving not just doctors, but our incredible neonatal nurses, pharmacists, cardiologists, and the ECMO teams. And at the center of it all is the family, who need our clear, honest, and compassionate communication every step of the way. Thank you so much for joining us on this deep dive.
And just a reminder, this AI-generated information is for educational purposes for trained neonatal clinicians only. It is not a substitute for independent clinical judgment. Always consult the current national and local guidelines.